Good afternoon, everyone. I think we'll get started. I'm Tom Freeman, and it's my pleasure to introduce to you Dr. Melad Marbeen, who is a candidate for the degree of Master's in Clinical Science and Family Medicine this afternoon. Dr. Marbeen is a graduate of the medical faculty at the University of Baghdad, did a 2-year internship at Kirkuk in Iraq, and then came to Canada and did the residency program here in London. She then entered the academic enhanced skills year and has completed all the coursework and is going to present to us the results of her thesis. She's a practitioner at the Oxford Medical Centre, which I think all of us know, or most of us here in London know, and at the Chelsea Park Long-Term Care. She's the recipient of the Martin J. Bass PSI Memorial Award in Family Medicine and the John F. Sangster Graduate Studies Family Medicine Award as well. Her thesis topic is Focused Practice and Enhanced Skills PGY3 Training in Family Medicine, a mixed method study, a very topical topic. And we have on as well Dr. McDonald in University of Calgary. Good afternoon, or good morning, I guess, for you. And would you then please join me in welcoming Dr. Marbeen to the podium.
Thank you. Thank you everyone for attending this presentation this afternoon. I would like to acknowledge my supervisors, Dr. Tom Freeman, whom you just heard from him, and Dr. Amanda Terry. Today I'm going to talk about some background that led to my research and the 2 studies that I completed, then move on into implications and recommendations for future research. The College of Family Physicians of Canada defines family physicians with focused practice as the family doctors with a commitment to one or more clinical specific areas as major part-time or full-time components of their practices. Family physicians with focused practice constitute a growing and an important component of family medicine workforce in Canada. Based on the latest National Physician Survey in 2014, over 30% of family physicians reported having focused practices. Attention to specialized fields in medicine develop at different stages of physicians' professional journey, including training period. As we know, that certification in family medicine requires 2 years of training in Canada, which is the shortest length of training in the Western world. Additional training can be pursued through the Enhanced Skills PGY3 programs. Interest in these programs has increased. In 2013, 21% of family medicine trainees pursued PGY3 training compared to 11% in 1995. The reasons for what influences both physicians and residents to focus on specialized areas of care in family medicine are incompletely understood. As such, a mixed methods study was conducted to understand this issue. So that brings me to the first study, which was about focused practice in family medicine. This was a quantitative study with 2 main objectives. The first was to identify the factors associated with having a focused practice among a sample of family medicine graduates in Canada, and the second was to examine the range of services provided by focused practice family physicians. The design was secondary analysis of data collected from the cross-sectional 2014 Western Family Medicine Resident Follow-up Survey. A paper survey containing 20-item questionnaires was mailed to all the physicians who graduated from the residency program between 1985 and 2012. This was supplemented by making available an online version of the survey. The survey was administered using modified Bellman method to maximize return rate, and the response rate was 42.5%. For the first objective of the study, and for the purpose of this study, the independent variables were 4 physician characteristics, including sex, years since graduation, training site, and PGY3 training. In addition to 3 practice characteristics, including location, population size served, and primary payment method. The dependent variable in the study was focused practice or non-focused practice physicians based on participants' response to the survey question that inquired whether the graduates consider themselves family physicians with focused practice as defined by the College of Family Physicians of Canada that I referred to earlier. Descriptive analysis were conducted to describe the characteristics of the sample. Then bivariate analysis were conducted to assess the associations between each of the independent variables and the dependent variable. Then multivariate logistic regression analysis was used for further assessment of the relationship between the independent and the dependent variables, controlling for all the variables in the model. For the second objective of the study, the range of the services provided by focus and non-focus practice physicians were compared and analyzed using chi-square tests. Then the top 10 procedures offered or performed by focus and non-focus practice physicians were analyzed and described. Focus practice physicians were further divided into those who have an office-based and those who have a non-office-based practices. The range of services offered by non-office-based and office-based focus practice physicians and non-focus practice physician groups were compared and analyzed using chi-square tests. Then the variations among physicians groups based on participants' characteristics were compared and analyzed using chi-square tests for the nominal variables and an independent t-test for the continuous variable. I'm going to move on to the results. This table describes the characteristics of the respondents to the survey. There were more male than female respondents, and the mean years since graduation were 13 with standard deviation of 7.9. The majority of respondents were urban program graduates, and 13.3% of them completed PGY3 training. The majority of respondents were located in Ontario, and most were practicing in inner cities and received payment via group payment models. Over a third of the respondents self-defined as focus practice physicians, and approximately 1/3 of focus practice physicians had completed PGY3 training. Results of the bivariant analysis as shown in this table indicated that PGY3 training, the size of the population served, and primary payment model were the variables statistically significantly associated with the dependent variable. Moving into the multivariate analysis results, 2 of the variables were significant contributors to the logistic regression model. In terms of PGY3 training, the odds of having taken PGY3 were 15 times higher in those with a focus practice. In terms of primary payment model, when compared to the physician in fee-for-service, those in a group payment model were less likely to be in a focus practice. Moving into the results of the second objective of the study, respondents reported whether they had provided a set of services included in the survey in their family practices. Less than 50% of focus practice physicians provided care in office settings, compared to over 90% of non-focus practice physicians. Focus practice physicians provided more emergency medicine and sport medicine services compared to non-focus practice physicians who reported more participation in variety of clinical activities, including after-hours clinic, house calls, palliative care, and nursing home visits. Examining the top 10 procedures offered or performed by focus and non-focus practice physicians indicated that nearly all the top procedures provided by focus practice physicians were those typically done in emergency settings, while the non-focus practice physician group provided more of the standard office-based procedures. When evaluating the range of services offered by non-office-based and office-based focus practice physicians and non-focus practice physicians, the analysis included and indicated the following. Non-office-based focus practice physicians offered more emergency medicine services, but they had less participation in all other areas of clinical services when compared with other groups of physicians. On the other hand, office-based focus practice physicians offered a broader range of services than their counterparts in non-office-based practices, but still less than the non-focus practice physicians. When evaluating the variation among non-office-based and office-based focus practice physicians and non-focus practice physicians based on participants' characteristics, the significant findings were the following. There was a greater proportion of non-office-based focus practice physicians completing a PGY3 compared to other groups of physicians. In terms of the population size served, 18.2% of non-focused practice physicians were located in rural and remote areas, as opposed to 8.7% among office-based and none among non-office-based focused practice physicians. In terms of the primary payment model, the office-based focused practice physicians were more likely to be in a fee-for-service or group payment model compared to non-office-based focused practice physicians who were most likely to be in an alternative payment plan. I'm going to move on into the second study, which was about PGY3 enhanced skills training. This was a qualitative study with two objectives. The first was to explore the perspectives of PGY3 residents regarding their decision to pursue enhanced skills training and to understand the career intentions of PGY3 residents. This was a qualitative descriptive study. Residents accepted in the Family Medicine Enhanced Skills PGY3 programs at Western University in 2018 were recruited via email. We used a semi-structured interview guide to collect the data. The data was all audio taped and transcribed verbatim. A thematic approach to data analysis was utilized. After the interviews had been transcribed, each investigator, including myself, Dr. Freeman, and Dr. Terry, read and coded the transcripts individually. Subsequently, we met as a team and discussed the codes, key ideas, and emerging themes. The final sample included 10 residents. There were 4 males and 6 females, ranging in age from 26 to 33 years. Participants were from urban family medicine programs, and there was a variation in the type of PGY3 program of participants. Residents' decision to pursue enhanced skills training and their career intentions were subject to influences arising from family medicine context, family medicine training context, and resident context. These form the 3 main themes. I'm going to talk about each theme and its related subthemes. Within the family medicine context, participants placed an emphasis on the importance of obtaining additional knowledge in particular field to meet certain population needs. And they provided an insight about their perceived responsibility of being ready for anything, as indicated by this participant. We see a little bit of everything, and it's interesting because we don't actually get to pick what we see. What we see kind of picks us, and we just have to respond to it. And so, we have to be ready for anything. Study participants were consistent in identifying the complexity of family medicine as an important factor that influenced their decision. They commented on the difficulties posed by the expansion of medical knowledge and dealing with uncertainty in general practice, in addition to workload. They considered PGY3 training as an opportunity to become experts in areas of special interest and ultimately as a way to overcome the perceived challenges of family medicine, as indicated by this participant. I found that for me, the uncertainty that comes with family medicine was a little bit unsettling, and I saw PGY3 as an opportunity to become expert in a topic that is still within the scope of family medicine. Participants also identified the evolution of family medicine's landscape of care and the uncertainty about the current and future profile of family medicine. They pointed out that pursuing enhanced skills in specialized fields will allow them to undertake the different roles in the medical system and establish a sustainable career, as stated by this resident. I think PGY3 fills a niche that we need to do. With the changing politics of family medicine, we don't know what the outcomes are going to be. With government's proposals, they're introducing more nurse practitioners, more nurses to do some work that family doctors do. And a lot of people are saying that family physicians will have to subspecialize. Moving on into the second theme, family medicine training. Among the residents interviewed, there was a sense that the core 2-year family medicine training was too short to achieve the many competencies required to practice family medicine in different settings, as stated by this resident. I feel there is a lot of knowledge to know. Personally, I think it's kind of crazy that's only a 2-year program. Additionally, participants indicated that obtaining credentials through PGY3 training would facilitate career opportunities in certain domains, as stated by this resident. I want to practice in place, and I know some of the bigger hospitals, they don't officially say this, but they won't consider you unless you have the added competency. The third theme, resident context, was identified as an important theme in understanding the overall experience of participants as they decided to pursue enhanced skills training and determine their future career plans. Participants articulated how their individual factors, including their unique personal and professional interests, were influential. Participants' plans for future practice were different. Some were planning to practice predominantly in the area of specialized training. Others were planning to have a mixed practice that included family medicine and their areas of special interest. Participants accounted for the flexible nature of family medicine, which enables graduates to choose the scope of practice that meets their personal plans, as stated by this participant. In Canada, you have the opportunity to really make your practice whatever you want, however you want, whether that's inpatient, outpatient, whatever demographic you want. You really have a lot of flexibility. Participants' intentions were driven by the type of PGY3 program as well as system and lifestyle factors. They believed that having variability in clinical practice was important for avoiding burnout and maintaining an ideal work-life balance, and they articulated how this could be facilitated by completing a PGY3 program, as mentioned by this resident. I think one of the ways doctors can avoid burnout is to have a more varied career. I see the PGY3 year as working to prevent kind of that emotional drag that medicine can be. Findings from this study indicate that the intended career pathways of PGY3 residents are variable, governed by forces exerted by the family medicine discipline and training context and individual residents' circumstances and aspirations. Both of the studies have several limitations, but to name a few here, participants were graduates and residents of a single family medicine program in Ontario. Therefore, these findings may not be transferable to other Canadian programs. The quantitative study was based on a cross-sectional survey that could not examine the changes in the career trajectories of individual physicians over time. The quantitative data are 5 years old, and there could be important changes in practice patterns since. Participants of the qualitative study were from urban family medicine programs, and their practice intention could have been different from rural program residents. When findings of both studies are compared and integrated, common themes included the following. PGY3 training is a significant factor associated with focused practice. System factors and payment strategy could influence physicians' practice pattern. Findings from the quantitative study showed that the clinical activities of focused practice physicians were mostly dedicated to specialized field, especially among those who worked in non-office setting. On the other hand, the career plans of PGY3 residents in the qualitative study were variable. However, commitment to comprehensive family medicine was not clearly conveyed as a career plan by the majority of participants. Results from both studies offer baseline data and insights for family medicine education, workforce planning, and policy making. It's important for family medicine departments to reevaluate the objectives and training environment of the enhanced skills programs to ensure that graduates' future practices do not impact access to comprehensive family medicine. In addition, healthcare planners and policymakers may recognize that the clinical services provided by the majority of focused practice physicians were limited to areas of special focus. Different initiatives could be taken to encourage these physicians to commit to a broader scope of practice and facilitate their inclusion in family medicine and practice groups. The study provides important information about the factors related to focused practice and PGY3 training in family medicine. However, future studies are required to provide further insights about the topic. Like additional studies are required to look at focused practice physicians who did not do PGY3 to examine what influenced them to choose their focus and what shaped their career path. In addition, future studies can examine if the trends to focused practice and enhanced skills training in family medicine are meeting community needs. Also, future studies from other training programs and regions of the country will provide further understanding and a more robust picture about the trend to specialization within family medicine in Canada. Thank you. Questions?
Melad, thank you very much. Very interesting study. I'm struck by your analysis of the qualitative responses by the focused practice physicians. They're very personal and individual. When you ask comprehensive family physicians what satisfaction they derive from their practice, it's often about family medicine relationships with patients over time. Did you get any sense that that was driving some of the focused practice physicians in your comments with them?
Like you mean the second study with PGY3 residents?
Right.
The residents, when they were describing the discipline of family medicine and their responsibilities, they actually made comments that about the importance of patient-doctor relationship. However, I did not see that was a driving force or an important influence when they were thinking about their future practices. As you mentioned, it's more personalized. That's how we found that the resident context, individual factors were very important. And the other thing, if we think about it, those residents, they were still at the transition period to practice, so that could explain why their answers is different than physicians who are already established and practitioners and already established some relationship with patients to see that effect or influence.
Good, thank you.
Welcome.
Thanks a lot. That was excellent. This past year, as president of NAPQUAC, I've been asked to go to a number of meetings in the U.S. And very frequently they said to me, "Oh, you have a 2-year program. Should we go from a 3-year to a 2-year?" And I just go, "No." But I'm curious, based on what you learned from the study, just your ideas. I mean, this is not part of your defense. This is just, I just want to have a conversation with you about this in terms of what your thinking is. Should we be going to a 3-year, or should it just be for enhanced skills? What are your thoughts?
If I depend or just think about what the residents said who were doing the enhanced skills program, they specifically, or few of them, they mentioned the importance of the accumulative exposure to anything, any learning environment or anything. So that itself, if we're thinking about that, the third year is important, is just from the fact that some of them, they felt that they need more exposure to things, to be more expert, to feel more confident to go and practice. So it depends whether we're doing 3 years of family medicine, general family medicine. That's different than if we're doing 2 years of general family medicine plus a year focused on one area of special interest.
Because in the U.S., it's 3 years of family medicine. So part of their argument and their consideration of going to 2 years is because their numbers going into family medicine are much, much lower than ours in Canada. So their goal by 2030 is to have 25% of the graduating medical students going into family medicine. So they're looking for carrots. They're looking for things to lure, students to go into family medicine. So it's a big issue in the U.S. and I think it's, and I think we in Canada are struggling sometimes. Should we add a 3rd year? It's just so I think that your work is really important in contributing to that. So it's great stuff.
Thank you.